anterior post and cores and everything. And sometimes you find that out of all the 8 veneers, there is one veneer that keeps popping out, keeps coming off, keeps coming off. Why? It's not because of your bonding. You use multiple bonding techniques, you use newer cements, and the result ultimately remains same. The reason is that it is coming in protrusive interference. Right? So we need at least 2, if not 4, at least 2 teeth should come in contact. Now let us see this case and let us calculate, what is the importance of occlusion. Now this patient came to us with a single, missing central incisor, and this was around maybe 10, 12 years back, maybe 13 years back. So I saw this case, looks very good. Can I go ahead and do an implant here? Doesn't seem to be a problem. So I went ahead. I do not have any CBCT because 12, 13 years back I was extremely confident in my implantology. Now I am not. Because now I do not work without CBCTs. 13 years back CBCTs were installed in my eyes. Even without seeing the patient I can tell that I can do an implant there. Okay, but now I see this, I go in and install an implant, do my GBR. This is how I give the final prosthesis. Looks very good with the midline diastema. You can see the jagged margins of the incisal edge matching with the other teeth. So I used everything what was there in my prosthetic dentistry in this case, and it was very fine. One fine day, around 1.5 years after the treatment, the patient called and said, "Doctor Sahab, something is moving." So I thought maybe the screws become loose with time, and so I called this patient to tighten the screw. I tell him, "Okay, you come and let's see." So this patient comes to me, and by that time I have attended a few courses on occlusion, and I have understood what is to be checked, and I asked the patient to give me a protrusive. Do you see what is the problem in this case? When I finished this case, I placed this crown, I never checked protrusive. Plus, getting a high point on protrusive is not a very big problem. That is why for 1.5 years, this patient never came with a problem. 1.5 years it was fine. After 1.5 years, he got this slight movement when he came. So I understood that there is a movement. I slightly reduced it so that I do not get those protrusive contacts. This is how the crown was mobile. Now if you can see this and tell me, is it the crown which is mobile, or is it the entire apparatus which is gone? Right? So I charged around 35,000 from this patient. That's a good enough charge for an implant. That too in 2012-13. And I spent around 5,000-6,000 on an implant, some grafting membrane, and this I earned around 22,000 out of this case. And this fails in 1.5 years. And I know internally that it is my fault. Right? So how do I manage this patient now? If this was your case, you would have told him to pay again and get it done, or you would have asked for some amount that, okay, give me 10,000 or 15,000. What you would have done as a clinician? This is 1.5 years. This is not 15 years. 1.5 years.
We will have replaced it. We will replace it.
We will have to do it because our practice also runs on our relationship with the patients and their patients and all relatives. So what do I tell this patient now? So I told him that I'm going to put some medicine to make this implant firm, and then after 2-3 days we'll give a call on that. What did I do for 2-3 days? Why did I take those 3 days? To decide a reason, to fabricate a story and put it in front of the patient, to tell that I am also not at fault, you are also not at fault, it's God's fault. Right? To fabricate that. But anyways, same day in the night around 11:30 he called and he said, "Doc, there is a problem." So I understood. There has to be a problem. When he said that the entire thing with the screw has come out, I was already morally not very satisfied. So I said, okay, there is nothing to worry. We will, anyways we were supposed to change the crown, so we'll do it again. He said, actually I was playing with my daughter and my daughter hit mobile on the same tooth and it fell down. That is why I always say in implant dentistry, karma is very important. At least I saved myself from that kid. right? And the patient thought that it's the daughter's fault. So I said, oh no, don't worry. Anyways, we have to go ahead and change it. But now comes the real part on how to manage it. As sir also rightly said that if it fails around 1.5 years, it's my duty to change it. Now, when I open the site, this is what I get because the implant was mobile, there is fibrosis, the bone is lost, and you can see how the bone looks now. What do I do now? I open the flap, I install a new implant. There is a definite need for grafting. I go into the patient's ramus. First, I cut a titanium mesh to record, put it on those areas. I will take out autogenous bone from ramus, put some autogenous bone there, fix my titanium mesh with tacks, cover it with the autogenous bone, further cover it up with the xenograft, covering the titanium mesh over a bioguide membrane, tacks and closure. 35,000 was what I charged. 15,000 I spent in the first phase of treatment when I did implant and other things. 45,000 50,000 I've spent till now, right? And at this stage, at 9 months, can you see there is a slight exposure of mesh? But it's okay, it's not that bad. And he said that I'm okay with the Maryland, I have to travel out of India for 6 months, so I'll be coming back in some time. I said, okay, you come back. The longer it is better, that is what is our thought process. And he comes after 14 months. This is how he comes after 14 months. The entire soft tissue is lost. I can see the mesh. What do I do now? I can see the mesh and I know that it is a mess now again. So we open up the site, I remove the titanium mesh, I place a mucograft, another 18,000, seal it, close it with the sutures, allow the area to heal. This is how it completely heals after a month, and then I go in and restore his smile. So I spent around 1 lakh rupees treating this patient. A lot of stress, a lot of money, a lot of time, everything goes in. What went wrong in this case? Where did I lose this case? Just one small high point, that too in protrusive. When do we do protrusive? Do we go home and keep doing protrusive? When do we do protrusive? When you're biting, when you're incising, right? When you're eating a burger, when you're eating a pizza, when you're eating a carrot, when you're eating an apple. That means we do a lot of protrusive. We do not realize, but we do a lot of protrusive. That's why protrusive is so important. And I have just shown you one of my failures. I have a 3-day session on my failures. Failures of THIRUVALLUR, there is a 3-day course. Right? So this is how we ultimately restore it, but you can see where we go in lost in this situation. So we know about MIP and we now know about protrusive. So if there is a single implant crown, should it come in protrusive contact or it should not? What is your final call? It absolutely should not come in any contact. That's the beauty of understanding occlusion. A single maxillary incisor crown will not come in contact in centric, will not come in contact in protrusive, will not come in contact in lateral, which means a single anterior implant will be totally devoid of contact. There will be absolutely no contact, right? Now when we talk about the lateral movements, right? When we talk about the lateral movement, you have heard about these two terms, canine guided and group function. Where do we give what? If there is a natural canine present, I give a canine guidance. If there is a natural canine absent, I will always give group function, irrespective of whatever implants I am placing, wherever implants are being placed, right? So we have talked about MIP, we have talked about protrusive, we have talked about lateral. Is something left now? So if I am talking about protrusive, is that movement inside out or is it outside in? Protrusive. Inside out. What about lateral? Inside out or outside in?
One side inside out.
The side where the contact comes. Inside out. But if you chew, what is that movement? Just try chewing when you chew a chewing gum. Is it outside in or is it inside out? When you chew, it is outside in. So in the entire process of occlusion which we have done till now, we have not even touched the chewing pathway of the patient. We have talked about protrusive, we have talked about lateral, we have talked about centric, but we have not talked about how the patient is going to chew. So the fourth important component is the chewing pathway. What you see here is the chewing pathway. How do I check the chewing pathway? I put this articulating paper in the patient's mouth and ask the patient to chew. Am I holding the articulating paper here? No. You have to leave the articulating paper free when the patient is giving you a chewing food, a chewing pathway. So the concept of chewing pathway was given by John Coyce. Have you heard his name? Have you heard about Coyce deprogrammer in full mouth rehabilitations? Right? There is a deprogrammer called as Coyce deprogrammer. So he is the person who did it. He is the person who talked about chewing pathway establishment. It's a complicated pathway, P1, P2, P3, how do you adjust that? But clinically what we need to know in chewing pathway is that when the patient chews food, you have to make sure that there are no contacts on the non-functional surfaces. That's it. Right? But the problem is, which paper to be used where? What thickness? What color? What are the different colors of articulating papers which you see? Blue and red. Where do you use blue? Where do you use red? Whichever your assistant takes out from the drawer. Or when red is over, you use blue. Blue is over, we use. Or is there a specific way of using red and blue? Or if you are wearing a red shirt, you use a red paper. How do you decide which paper to be used where? Is it important or is it irrelevant?
Important, sir.
And how do I decide which thickness of paper to be used? What is the commonest thickness which you guys commonly use? 40 microns. For implants as well as for teeth? Am I clear? Is it 40 microns? All of you use commonly 40 microns? Some of us are, we have no idea what micron it is. It is a paper, it will give color, I will remove it. Right? So that is what we are going to see. We are not going to complicate it. We are not going into the nitty-gritties and complicate it so much that you will realize that let me go back to carbon papers. We are not going that way, we are not complicating it. Now we have understood that what is the problem. Is that part clear? MIP, protrusive and centric and eccentric. And which are the good marks? We are also clear with the fact that which are the good marks in which movement. What we need to know now is how am I going to check the good and bad marks and how am I going to understand that these are the bad ones, these are the good guys, right? So what do we do about it? We understand the tools of the trade. Now tools of the trade needs the articulating material. Have you seen these type of papers? You guys commonly use the ones on the right or on the left? Which one do you use? This one or the carbon paper? How many of us still use carbon papers? It's not wrong. I mean, even if you are using, that's fine. Anybody who uses carbon paper? Nobody. Nobody. I have been lecturing on occlusion for almost 12 years now. I have never given a lecture to an audience where nobody uses carbon paper. That means I am outside India if nobody is using carbon paper. Right? But okay, a lot of us also agrees, we also agree, we have been using it. But we'll understand why we should not use it, right? And what we should use instead of it. So when you are seeing these articulating papers which are on the left side, when you are seeing a carbon paper on the right side, let me tell you, both these papers are equally useless. Both these papers are equally useless. If you have them, go back, throw them into the dustbin. That's the end of it. We are not supposed to use them. Carbon paper, of course, is not an articulating paper. Now, if I see this, it is a full mouth occlusal bridge on implants, and I put an articulating paper, I ask the patient to bite, and the patient gives me these markings, right? Which will be the non-functional in this? This is mandible or maxilla? Mandible. Which is non-functional? Lingual is non-functional. Now, if I carefully see this, you can see that there is a big red mark on the first molar, right? Then you can also see some lingual spots on the premolars, right? You can also see a mesial marginal ridge spot on the last molar. Which ones should I remove? This is the first marking I get. I put a paper and this is the marking I get. Which ones do I need to remove here? All linguals? Or only that bigger lingual first and then redo it? See, we have to understand that whenever we are using a paper will always give us qualitative analysis. It will never give you the quantity to be removed. It is never a quantitative analysis. That is why we have to keep doing it again and again put paper, remove, again put paper, remove, because there is nothing in that paper which is going to tell me the amount of reduction required. It can only tell me this is the area where you should reduce, right? Now, which one should I reduce? Do I reduce all linguals? Do I reduce only the bigger mark? What do I reduce? You guys are taking so much to answer it. If this was in your clinic, by now you would have almost adjusted it. Am I right or wrong? By now, which burr do we commonly use for adjustment? Whatever is there on the arrow. Polishing burr. Whatever is put in there. Sir is absolutely right. We need to use some polishing burrs, but we usually do not focus a lot on it. Whatever is there. Now, what am I supposed to remove? To understand this, we have to understand how these articulating papers are made. Right? Once we know how they are made, we will be able to identify. So we'll come back to it. If I show you these three pieces here, on the left side, you can see there are white and red, white and blue dots. On the right side, it looks like a red paper, right? So all these articulating papers, they are white papers. On white paper, there are small color-filled balls. They make an articulating paper. Now, if there is a color-filled ball and the patient bites on it, what will happen to that ball? If there is a high point, what will happen to that ball? It will rupture, right? All of us have used mortar pestle. Whenever something ruptures, whenever you hit on it and it ruptures, where does it give color? Right at the center or at the periphery? At the periphery. So if I go back to this picture here, on that big red spot, can you see a small white dot in the center? That is what I need to remove. What were we removing till today? Everything. Whatever was on our way, we will remove it. Like a villain, whatever coming in my way goes to the highway. Right? So that is what is the difference between an articulating paper and a color paper. Now, if that ball, if I put a paper, the patient is biting on it and the ball has ruptured. Right? Can I put it back again? The same paper. It's already gone. That is why you will have to either change the side or you'll have to use a new paper. You cannot keep using a new paper. Our trend is to put a paper, ask the patient to bite. If there is no color, I will double the paper. Again put it and ask the patient to bite. By that time, saliva will make things wet. And then that paper will give you a big, huge blue marking. And you take out the biggest burr and you start removing everything. You know, and that's completely out of occlusion now. How many of you have got your work done from dent care lab? Satisfied with dent care lab? 90% dentists are very satisfied with dent care because you never have to touch the crown. They are always under occlusion. They're always, you will never find a good prosthodontist using dent care lab. Never. Why? All their crowns are under occlusion. People are very happy because they don't have to touch it. Let me tell you that when you bite heavily, when you chew, Your teeth are moving 40 microns in the periodontal socket. That's why sir is using a 40 micron paper. So 40 micron movement, can it be simulated in any model, any articulator, any 3D printer, any virtual design? No, it has to be done in the patient's mouth. So if your crown is not high and you are not adjusting it in the patient's mouth, that means your crown is out of occlusion, for sure. And that is what leads to a cascade of full mouth rehabilitations. Why are we running courses on full mouth rehabilitation? Every week, every 10 days, there is a course in a big city on full mouth rehabilitation. We are creating those cases by deharmonizing everything. That's good for the profession. I'm not saying it's wrong for the profession, but it's not good for the patients, because we are keeping all these bites and everything under occlusion here and there. So now have you understood how a high point will look like? It will clearly look like a bull's eye. There will be a small center white dot which needs to be eliminated. And as sir said that you have to use which kind of a burr? Small polishing burr. Can I use a big burr and reduce that point? I'm going to end up removing everything. So it has to be a small polishing burr. There is no quantitative analysis, so I will have to keep doing it. Which means checking occlusion is a costly affair. Checking occlusion is not a sasta affair, it is a costly affair. You have to use multiple papers and keep throwing those papers. Right? So we have understood how it is. Other than articulating papers, we also have some other materials which we need to have in our armamentarium. Now, if I talk about crown preparation, you can see a crown preparation here. Right? How do you check for occlusion clearance? See, we dentists are so precise, that we will just retract, ask the patient to bite, and we know where it is 1.3, where it is 1.4 millimeters, where it is 1.5 with our robotic eyes. Or the other option is you take a modeling wax, fold it into two, put it in the patient's mouth, ask the patient to bite. Then you take it out. Against the light, we are trying to see something which we do not know what exactly we are trying to see. Even if I know what I am seeing, I do not know which cusp is that. Am I right or wrong? And so, if there is something which is through and through, I'll take a burr and do an occlusion reduction once more. Is that right or is that wrong? So, if there is something with which I can check how much reduction is done, will it be very clear? So, there is something which is called as a fleximeter strip, 1 millimeter thick, 1.5 and 2 for metal ceramic, for zirconia. You can put this spray on it. I have put that spray, and can you now easily find that which areas I need to reduce more? That is important. Other than this kind of a problem, this happens sometimes with us. What we have written on the screen, does that happen with us? The crowns are beautifully seating on the model. In the mouth, they are not just going in, because your lab has trimmed the proximals. So what do? We try to put that in. We take a slight burr, slightly remove from the crown's proximal margin, slightly from the adjacent tooth, from both the sides, and eventually end up having space on both the sides. Does that happen or not? Because you have to adjust and fit the crown because the patient is leaving tomorrow, or he will not come back again, or all these issues are there, right? So how do I identify this proximal high point? There is something which is actually like a nail polish. I'm not asking you to use nail polish. It is like a nail polish, right? So you have this arty spot. What are we doing here? I am just painting this arty spot on the proximal surface. And when I am trying to put this crown in, wherever it contacts the adjacent tooth, it will give a mark. Like you can see in the last picture, there is a small mark. So I know which area is interfering proximally. So I can just slightly reduce that area instead of reducing the entire thing. Right? And all these things are available in the market. We can easily go ahead and use these products. Can you now clearly see which are the areas coming in contact proximally? And only those areas you have to touch. So whenever I am setting my tray for occlusion, I always keep a white paper. ये white paper का क्या role है? What is the role of this white paper? This is to train the patient. Our patients are not trained in giving centric, protrusive, lateral, MIP, chewing pathway. And I do not want them to get trained with a color paper, because then I have to sit down with a rubber and erase all those markings. So I will do all this training with a white paper or a tissue paper. Every time that patient comes to me, I will first do this training session, so that when he has to give me an actual bite for occlusion, the patient is able to do that. Right? That is why this white paper is always a part. And what are these holders which you see here? Has anyone of you used these articulating paper holders? This is a must-buy instrument. We are talking so much about the paper. If I am using a tweezer and that paper keeps moving, will it be able to give me a correct mark? This is a 500-600 rupees instrument, not something very costly. This is to hold the articulating paper. Now what is the concept of this red and blue? Where do I use red, where do I use blue? You know, actually there are 4 different colors of paper. Right? You have red, you have blue, green and black. One is for MIP, one is for protrusive, one is for light lateral and one is for left lateral. But we are not going to complicate it so much. Right? What we are going to do is we are going to use blue paper for centric and red for all other movements. Which is the most commonly used thickness? As sir said, it is around 40 microns. That is the most commonly used. Why? Because 30 microns is the depressibility of PDL and 10 microns is the lateral movement of PDL. So totally 40. That is why we commonly use a 40 micron. But let me also tell you that this 40 micron paper will not work on glazed crowns. How many of us do a biscuit trial? Unglazed trial or biscuit trial? Do we do it? Sometimes maybe if the lab asks you to do it, when the lab is not very sure. Otherwise we don't. So which means 40 micron paper clinically is of no relevance to us. You would have noticed it. If you are using 40 microns, it is very difficult to get those marks on glazed porcelain. Right? So how do I get those marks? Because every time it's not possible to do a biscuit trial. You always coat the paper with Vaseline. Why do I coat this paper with Vaseline? Because Vaseline holds the color. If I am not putting Vaseline, what happens is the moment you press your aerator, air and water comes out. What does it do to the color? Then you and your memory. This was the area where I saw color few moments back. That is why you always coat your articulating papers with Vaseline. Vaseline is hydrophobic and Vaseline allows that color to stay on the occlusion surface of the teeth. So when we talk about implant occlusion, how different it is from general occlusion, that is what we need to know. How different is implant occlusion from general dentistry occlusion? The 40 micron movement of your crown, will the same movement be there in the implant?
No.
Yes or no? No. Which means when I am chewing, all my chewing teeth are going down by 40 microns. What is staying up? So which is going to take up the maximum load of chewing? Implant. That is why it fractures, it fails. Which means I have to very carefully manage the occlusion by 40 microns, so that when the patient chews, only then the implant comes in contact. It should not come in contact immediately. How do it? That is what is called as implant protected occlusion. You try to protect the occlusion. When do I check for implant occlusion? At what phase of treatment?
Before planning. Planning stage. Planning first.
How do I check occlusion in planning?
There is in proper intercostal space.
Space, okay. If space is there, thickness of, I mean, I'm asking about which stage, I mean treatment planning, surgical phase, or only I check occlusion when I'm putting the final crown.
During restoration trial, before
Sir wants to check it in trial, madam wants to check it in treatment planning. And all others are waiting.
During planning